it's just an accidental co-occurring phenomenon. And I'll bring a metaphor of diabetic kidney disease to the table. Patients with diabetic kidney disease with diabetes are increased risk of having kidney disease. We can treat that kidney disease in a couple ways. We can treat it with a change in the fundamental process that's involved in the pathogenesis of diabetes, and change diet and exercise, and that will improve kidney disease. Or we can treat the fibrosis with antifibrotics that are directed specifically at the kidney disease. Both have some validity. Okay? Both are supported by the scientific evidence. But if we can get at something that's fundamentally involved increasing the odds ratio of complications of autism, then we're doing something more. We're changing the whole field of things that a child might have to face over the course of their lifetime. So I guess so this idea of construct validity is incredibly important, because if we just call it something similar, so if anxiety is just this isolated concept like kidney fibrosis, then we treat it just like kidney fibrosis with a drug developed to do that. But if we think of it as in the broader context of the pathogenesis and pathophysiology of autism spectrum disorders, then we do more for our children.
Absolutely.
I wanted to build on that because I agree that the speakers were fascinating, and it got me thinking, because I'm going to talk in my talk about arousal dysregulation potentially being a trigger, and feeding into, and I don't know if this is correct or not, but let's say anxiety, GI problems, insomnia, and Dan already brought up the connection between GI and insomnia and what might be driving that.